do you think that skilled physical therapy, because I think that's the big thing. It's like, what is considered skilled treatment or skilled physical therapy? And I think that people don't consider appropriately dosed loading or appropriately dosed training or behavioral modifications or patient education necessarily as quote unquote skilled physical therapy. Do you consider that? Because I do. Do you consider that skilled physical therapy, being able to educate somebody on behavior modifications, graded exposure, that type of
Absolutely. Thing? Again, it's the bit that everybody thinks is the easy bit. It's the simplistic bit, and they just undervalue it. And I often see them doing it horrendously wrong because they don't value it as well. So they don't give it the credence and they don't give it the time that they should do. But yeah, I think, these, I hate the term that's often used with this sort of stuff, the soft skills, your communication, your empathy skills, your motivational skills as a physiotherapist working with somebody that's in pain, that is pissed off, that is anxious, that is worried, that is stressed, that is scared. Our ability to be able to instill confidence and reassure people that they're okay, they're not broken, and give them that proof through graded exposure and graded activity that they can get better, there is light at the end of the tunnel, is a hugely skillful task. And it is something, as I say, that I don't think many physiotherapists do very well because they don't value it. Their beliefs are that they get people better with the hands-on techniques, with the sticking the needles in, and that's what's going to do it better. I'm like, that shit don't matter. What matters more is the stuff at the beginning. But that's the bit that I see most physios rushing through and just totally devaluing.
You see that with, I'm assuming you see that with the shoulder as well. Do the physicians, do you get any pushback with some of the referrals that you get from the physicians in regards to the treatments that they believe that the patient should get, or the diagnoses that the patient receives? Do you have to undo some of that stuff sometimes?
Yeah, it's a fine line you have to tread here. But yes, I do. I get a lot of dubious diagnoses sent down via consultants that I totally disagree with. And I think this is just due to more understanding and acceptance of uncertainty. And I find that our orthopedic colleagues are not that happy with uncertainty. They don't understand, I think, what else could also be causing pain in this particular person. And again, the other factors around psychosocial interventions, but also just different pathologies. I still have surgeons that still think they can differentiate supraspinatus from infraspinatus in manual muscle testing and shit like that. And so they tell me, this person clearly has a supraspinatus dysfunction because they can do this clinical test and they can tell. And I'm like, it's not that simple. It's not like that at all. So having to go back and say to these guys and girls that actually I don't think that it's just this, it could be. What I try to do is do that sort of bit more, and believe it or not, I can be tactful, a little bit more tactful, saying, yeah, that is a plausible diagnosis and explanation, but it could also be X, Y, Z, could also be A, B, and C, could be other factors as well. So I try as best as I can, but some are more receptive to it than others. Surgeons don't listen to anybody else. Surgeons don't even listen to other surgeons, let alone physiotherapists. It's their mindset. And that's not having a go at them. That's just the way it is. But you ask any orthopedic surgeon that's quite rational, they'll agree with you. They'll say, yeah, fuck it, I won't listen to anybody else. I know what I'm talking about. But then again, I think some physios are like that as well.